Welcome to MediCrush, where I help you crush your medical exams. In this video, we will be covering dilated cardiomyopathy. Now, in terms of the name cardiomyopathy, myopathy means disease of the muscle and cardiac heart. So therefore, cardiomyopathy, simply put, is disease of the heart muscle. Now, to understand this, remember that the myocardium is the middle layer of the three layers of the heart. That's the layer that has the muscle that does most of the contraction and relaxation of the heart itself. Now, there's three types of cardiomyopathy. The first and most common by far is dilated cardiomyopathy. That's the one that we're going to focus on in this video. The other two types of cardiomyopathy is hypertrophic cardiomyopathy and restrictive, but we'll cover those in another video. If I suspect any of these three types of cardiomyopathy, the most useful non-invasive test is an echocardiogram. That'll tell me which of the types that I have and sometimes even tell you the cause of the cardiomyopathy. So back to dilated cardiomyopathy. Let's focus on that one right now. So in this case, what happens is the heart muscle is not able to do its job, is not able to contract properly because the heart becomes dilated and very weak. It's so tight and so weak. So the key for this in terms of the pathophysiology is you have impaired systolic function. But to understand that, let's think about what is the job of the heart. Your heart has two jobs. It has to contract to get blood forward, and then it has to relax to fill with blood to start that whole process over again. So in this case, if you have a problem with the heart being able to contract, we call that systolic dysfunction. So in dilated cardiomyopathy, you have this impaired systolic function, or you have systolic dysfunction that results in increased compliance. The heart becomes bigger and bigger and bigger, hence the name dilated cardiomyopathy. Now, the key about this is that the heart becomes bigger, but not better. So therefore, the heart becomes bigger, but it becomes weaker. So think of dilated cardiomyopathy as a weak, flabby heart that's just so tired, it can't do any contraction. That's a key feature for this condition. Now, very important, this is going to sound just like heart failure with reduced ejection fraction. Now, if the cause of the heart failure is cardiac related, we call it heart failure with reduced ejection fraction. So for example, if I have a massive MI, right, a massive myocardial infarction, that can result in heart failure with reduced ejection fraction. If the cause is not cardiac related, but it affects the heart, it poisons the heart, it harms the heart, we call that dilated cardiomyopathy. So what are some of the harmful things that can happen to the heart that's not cardiac related but affects the heart? The first one is no one knows, idiopathic. That's the most common cause of dilated cardiomyopathy. We believe part of it has to do with undiagnosed viral infections or genetic causes, but the causes that can be idiopathic is the most common cause of dilated cardiomyopathy. There are certain substances that can poison or harm the heart as well. Those substances are going to be chronic alcohol use and cocaine use. Remember, cocaine is a sympathetic stimulant. So if I'm taking cocaine often, my heart is kind of pumping and it's working so hard, it can tire out eventually. So alcohol use, cocaine is a very important causes of dilated cardiomyopathy. Viruses, especially Coxsackie virus type B. Remember, that's the same exact virus that can cause hand, foot, and mouth disease in children and herpingina. Two very important complications of Coxsackie virus infections that can occur is aseptic or viral meningitis and also dilated cardiomyopathy as a complication of Coxsackie virus B infection. It could be COVID or influenza. Any virus can cause this, but those are the most common one is going to be your Coxsackie viruses, your echoviruses, which are part of your enterovirus family. Medications are very important as well, specifically anthracyclines, such as doxorubicin, is a very important chemotherapeutic agent that we use, and that can cause direct damage to the heart due to issues with reactive oxygen species. Also, trastuzumab as well. So trastuzumab is commonly used for breast cancer, specifically HER2 positive breast cancer. And if I'm going to put someone on trastuzumab, I should get an echocardiogram. And if they develop symptoms of cardiomyopathy, I should also get an echocardiogram to rule that out as well. Now, pregnancy and postpartum complications can also result in dilated cardiomyopathy. So the pregnancy and postpartum period, they may also present with symptoms of cardiomyopathy. Now, B1 or thiamine deficiency is another very important metabolic cause of dilated cardiomyopathy. Now, B1 is very important for cells that function very high level. So, for example, your nerves and your heart can be affected if you have a B1 deficiency. As a matter of fact, the way it presents with a B1 deficiency is what we call dry beriberi. That's one of the 4 ways it presents. They get peripheral neuropathy because, again, the nerves are commonly working and now they don't have enough fuel, so they get a peripheral neuropathy. Eventually, they can get what's called wet beriberi, which is where they get dilated cardiomyopathy. They get peripheral edema, they get pleural effusions, they get crackles and rails. We call that wet beriberi. They can also develop Wernicke's encephalopathy because, again, it damages the nerves in the brain, and they can develop Korsakoff's dementia. Those are the 4 different ways that a vitamin B1 deficiency can present: peripheral neuropathy, dry beriberi, dilated cardiomyopathy, wet beriberi, Korsakoff's dementia, and Wernicke's encephalopathy. In worldwide, certain infections can also cause dilated cardiomyopathy, especially in Central and South America. Chagas disease, which is caused by the assassin or the kissing bug, can result in developing large organs. I can get a megacolon, I can get a megaesophagus, and a megaheart as well. And some other variations could be things like sarcoidosis and radiation therapy. But the key is that something is harming the heart that's not cardiac related. These are all non-cardiac related, but eventually they cause damage to the heart. They poison or harm the heart. So how does it present? It presents just like heart failure with reduced ejection fraction. They get progressive dyspnea, especially if it involves the left side. They can say, I get shortness of breath when I walk 5 blocks. Whenever I lay down, I get orthopnea. All the fluid in my legs comes to my heart. I have to sit up with 1 pillow or 2 pillows or 3 pillows. Then get paroxysmal nocturnal dyspnea. I go to lay down, same concept. The fluid from my legs comes to my heart, and it causes me to feel short of breath. If the fluid pools in my legs, I can get peripheral edema. If the fluid pools in my lungs, I can get pulmonary edema. Now, a very, very high yield fact to know about dilated cardiomyopathy is look for what's known as the third heart sound, or the S3 gallop. If I see an S3 gallop, that signifies filling of a dilated ventricle for whatever the cause is. If it's cardiac related directly, we call that heart failure with reduced ejection fraction. If the cause is non-cardiac, idiopathic, alcohol, B1 deficiency, pregnancy, trastuzumab, viral, idiopathic, we call it dilated cardiomyopathy. So that's a very important finding on examination, is an S3 gallop or a third heart sound that indicates 2 things: systolic dysfunction and dilation of the heart chambers. Now, I'm going to get a chest radiograph, and what I'm going to look for is evidence of cardiomegaly. So the heart will become enlarged on the chest radiograph. Now, the most important non-invasive test is an echocardiogram, and you look for 3 specific features that describes a weak, flabby heart. The heart is dilated, so you can look for dilation of the ventricle chambers. The walls become thin and have a decreased ejection fraction. I think of it like a balloon. If I was to blow into a balloon, the balloon will get bigger, the ventricles gets bigger, the walls become thinner until the balloon pops. So therefore, look for those 3 key findings: dilated ventricle chamber, thin ventricular walls, and a decreased ejection fraction. Now, how do I treat dilated cardiomyopathy? The exact same way as heart failure with reduced ejection fraction. The difference is that it's non-cardiac related. So therefore, the same 4 pillars that we use for guideline-directed medical therapy can be used for dilated cardiomyopathy as well. So we start with an angiotensin blocker, most useful drugs for mortality reduction, and that could be either sacubitril valsartan, which is 2 drugs in 1, or an ACE inhibitor, which is the most important singular medications. In addition to that, we often put them on a beta blocker to also help to reduce the mortality of this condition. Third, we can put them on a mineralocorticoid blocker, aka it blocks aldosterone. And the 2 drugs are going to be either spironolactone or eplerenone, are the drugs that will block aldosterone. That blocks the holding on of sodium and water that causes the harm in cardiomyopathy. And the last of the 4 drugs you can add on is an SGLT2 inhibitor. Those are the Flozin drugs that we use for diabetes, but remember, they protect the heart and they also protect the kidney as well. So those are drugs that we can use for this condition. Now, there's 2 subtypes of dilated cardiomyopathy that you should be familiar with. The The two subtypes are going to be myocarditis and stress, aka Takotsubo cardiomyopathy. So what does the name mean, myocarditis? Itis means inflammation, myocardium of the myocardium. So therefore you have inflammation of the myocardium that results in infiltration with white blood cells, that's the inflammation part, and necrosis. Now, who gets this most commonly tends to be people that are younger and was relatively healthy until some kind of trigger happens. Well, what are the triggers? Ironically, the same triggers that cause dilated cardiomyopathy. Remember, it's a subtype of dilated cardiomyopathy. So again, idiopathic, no one knows. It could be post-viral, and it could be any virus. Some big ones are COVID, influenza. Again, enteroviruses are very important. Coxsackie viruses, echoviruses are some very common ones. Bacterial causes, parasites, we said earlier, Chagas disease, for example. It could be autoimmune causes. It could be medications. Clozapine is a very important medication that can cause myocarditis. Now, clozapine is a drug that we commonly use for schizophrenia, especially for refractory schizophrenia. You try two neuroleptics and they still have symptoms, you may consider clozapine as a good drug for refractory schizophrenia. It has two very important side effects that I like to say the two C's of clozapine. The first C is for a CBC. I'm on clozapine, you want to monitor the CBC periodically because it can cause agranulocytosis. And the second C is for carditis. It can cause myocarditis. We said before, doxorubicin and anthracyclines can cause dilated cardiomyopathy and hence can also cause myocarditis. So how they present, look for someone that was young and healthy until one of those triggers happened. So I was young and healthy and then they presented one of three ways. The first way is with heart failure. So I was living my best life. I was young and healthy and I got Coxsackie virus or I got influenza or I got COVID and now I developed symptoms of heart failure. Remember the S3 gallop, I get pulmonary edema, peripheral edema, you now consider myocarditis in your differential. Or they can present with chest pain. Now there's two different ways the chest pain can present. The first way, it can present very similar to pericarditis. Sharp pleuritic chest pain that is worse with position. If you get a test question and you see that the P's of pericarditis, the chest pain is sharp, pleuritic chest pain, it's positional. I lay down, there's a P sitting in my chest, ooh, I sit forward, the P falls off, it gets better, right? And they have a friction rub and you're salivating looking for pericarditis and it's not there, then myocarditis will probably be there. It presents just like pericarditis. That's one of the ways they present with chest pain. The other way with chest pain it presents just like acute coronary syndrome. So instead of the sharp chest pain of pericarditis, they may present with a substernal chest pain or pressure that presents very similar to myocardial ischemia as well. And it can actually mimic an ST elevation in mind. They can have positive enzymes and even have ST elevations potentially. And the third and final way it may present is going to be with arrhythmias. Remember, it affects the heart muscle, so it can affect the conduction system. They can either have tachyarrhythmias, they can have bradyarrhythmias, or they can develop heart blocks as well. So again, look for someone who was relatively healthy, look for the trigger, and they develop symptoms either heart failure, chest pain or pericarditis, or ACS-like chest pain, or arrhythmias. Now, I'm going to get an EKG and I'm going to look for the classic findings of arrhythmias. Most commonly be sinus tachycardia, but it could be any slow or fast rhythm. And again, chest radiograph will show evidence of an enlarged heart. Now, if I get an echocardiogram, which is the most useful non-invasive test, remember the same three findings of dilated cardiomyopathy. I'm looking for a thin ventricle wall. I'm looking for a large, weak heart. And how do I know it's weak? Because I look for a decreased ejection fraction. Those are the three key features of myocarditis and dilated cardiomyopathy. Now, if they were to ask you what is your definitive or criterion standard test to pick up myocarditis, the answer is a biopsy of the heart muscle. Remember, the pathophysiology was you have inflammation of the heart muscle and necrosis. So in biopsy, I will literally see those two things. I'll see lymphocytes and monocytes all infiltrating the myocardial tissue, and there'll be evidence of necrosis, which indicates the inflammation and the cell death that occurs with this condition. Now, the management depends. If it's very mild, it's usually self-limiting. You can just do supportive management for most of those patients. If they present with symptoms of heart failure, then you could treat it very similar to dilated cardiomyopathy. So again, some kind of angiotensin blocker, a beta blocker, diuretics, and spironolactone if need be for these patients. You want to try to avoid NSAIDs in these patients whenever possible, just because NSAIDs may delay the healing and repairing of the myocardial tissue after the necrosis, and therefore, whenever possible, we try to avoid NSAIDs if we, to reduce damage to the heart. Same thing with digoxin. Digoxin can also make the heart work harder, and if I'm trying to repair myself, working harder is not going to help. It's going to just cause more harm than good. And any other cardiotoxic medication you want to try to avoid if possible, whenever possible. Now remember, if I see an S3 gallop or third heart sound, you should be thinking there's some kind of systolic dysfunction and the heart is dilated for whatever reason. If the cause is cardiac related, for example, post-MI, we call that heart failure with reduced ejection fraction. If the cause is non-cardiac, idiopathic, viral, doxorubicin, trastuzumab, pregnancy, postpartum, B1, then you think about dilated cardiomyopathy as the cause. Now, the third and the last subtype of cardiomyopathy that's dilated is stress or Takotsubo cardiomyopathy. Now, this is a transient dysfunction of the heart. You get what we call myocardial stunning, where what happens is the heart gets stunned for whatever reason, and it has to kind of recover and recoup. It's almost as if I was just sitting here and someone was to slap me, I'm gonna get stunned for a moment, and eventually I'm gonna get it together and I'll recoup. So your heart gets an injury for whatever reason, and it gets stunned. Now, who gets this condition most commonly? It's usually seen in older patients, especially post-menopausal women. Now, we believe the reason why it's in post-menopausal women is because after menopause, they lose the protective effect of estrogen on the heart. But the most important component of this is what we call the catecholamine surge. They get the surge of epinephrine, the surge of norepinephrine, and that results in the heart working harder, and that stuns the heart. So that surge of catecholamines is like the slap to the heart that stuns the heart is in this condition as well. So how do they present? They present just like acute coronary syndrome. It walks and talks just like an ST elevation MI. So they can present with substernal chest pain, they can present with dyspnea, they can present with an EKG that shows ST elevations just like a ST elevation MI. They can even have positive enzymes, which means that when they present to me, I'm going to assume that they're having an ST elevation MI. So why do I call it an all the way question? Because as a test writer, I'm going to have to treat it just like a STEMI and go all the way to the cath lab. I go all the way to the cath lab, and there should be no evidence of significant coronary obstruction, aka I ruled out atherosclerosis as the cause of this. Whew. If there's no atherosclerosis after I went all the way to the cath lab, I can then now get my echocardiogram, which will show me the classic finding of this condition. I'm gonna look for two things. I'm gonna look for systolic dysfunction, because remember, this is a type of dilated cardiomyopathy, and look for the classic apical ballooning, especially of the left ventricle. These are the two hallmark findings of Takotsubo after I went all the way to the cath lab and ruled out an ST elevation MI, right? And eventually the heart is going to be stunned, and eventually what should happen in most patients is that the heart should recover over a few weeks to a few months. Now, we call the Mayo criteria is very important. It kind of pretty much says what I just said before. They present with a STEMI symptoms. It looks like a STEMI, it walks like a STEMI, it talks like a STEMI. They have ST elevations, they have positive enzymes. However, I go all the way to the cath lab and there's no evidence of significant coronary artery obstruction. Whew, I ruled that out. So now I get my echocardiogram, which will show me that systolic dysfunction and the transient left apical ballooning that now rules in stress Takotsubo cardiomyopathy. Now remember, this is a diagnosis of exclusion. So number one, I ruled out an ST elevation MI due to atherosclerosis with the cath lab, and also make sure there's no evidence of pheochromocytoma. That's the fourth component of the Mayo criteria. What's like a STEMI? I go to the cath lab, there's no evidence of significant atherosclerosis, and I see evidence of left atrial or regional left ventricle systolic dysfunction. So when they present initially like similar to a STEMI, I'm gonna treat it like a STEMI. I'm gonna give them aspirin, I'm gonna give them nitroglycerin, I'm gonna give them beta blockers, I'm gonna give them statins, I'm gonna give them heparin, and go to the cath lab. Once I go to the cath lab and I ruled out atherosclerosis, then I will do supportive management, just conservative management, because again, usually within a few weeks, this gets better on its own. The heart gets stunned, it recovers, and then everything goes well in most cases. However, if they present in severe disease, such as like systolic dysfunction that's really, really bad, you may consider temporarily using the same drugs for dilated cardiomyopathy. So again, angiotensin blockers, beta blockers, diuretics, spironolactone may be used. But again, usually you could check them in a few weeks and see if they improved, and then you can discontinue once they improve. So now to test your knowledge, I'm gonna give you a few questions. And what I want you to do with these questions is that as you see them on the screen, pause it so you can give yourself enough time to answer the questions. Once you got your answer, then you can unpause the video, and I'm gonna kind of walk you through the question, how it's constructed, so you can become like the mind of a test writer instead of just being a passive test taker. So in this case, this person has progressive dyspnea and they have decreased exercise tolerance. So they have dyspnea and problems with the left side of the heart. You can see the heart is definitely enlarged and have a history of chronic alcohol use. Was that important? Remember that substances like alcohol and cocaine, they can poison or harm the heart. And so therefore, in this case, we're probably thinking that the alcohol use may be a risk factor for them presenting with the symptoms of dilated cardiomyopathy. Remember, if I have a dilated heart, the most important finding is that classic S3 gallop, that third heart sound. Remember, the third heart sound represents two things: systolic dysfunction and filling of a dilated weak ventricle, making the best answer here, choice D. So in this case, this young woman had breast cancer and she was treated with trastuzumab. Was that important? Remember that trastuzumab can cause harm to the heart. It can poison or harm the heart muscle tissue and result in dilated cardiomyopathy. Plus, she has an S3 gallop and evidence of chest radiograph of cardiomegaly. So remember, the most important test that's non-invasive is going to be an echocardiogram to look for the classic 3 findings that tells me you have a weak dilated heart. So the dilation is going to be the left ventricle enlargement. It's weak because it has thin muscle walls and they have a decreased ejection fraction. Those are the 3 key findings of dilated cardiomyopathy, as well as heart failure with reduced ejection fraction. So in this case, you have an older postmenopausal woman who presents with symptoms that walk and talk just like a STEMI, but they went all the way to the cath lab and there's no evidence of a STEMI, atherosclerosis. Whew, glad about that. Now I do an echocardiogram and I see evidence of apical ballooning, which is indicative of stress cardiomyopathy. Remember, the pathophysiology of this condition is a catecholamine surge. I get really happy news, I won the lottery. I get really bad news, I lost my house. That catecholamine surge can cause direct harm to the heart tissue and result in this condition. So in this question, you have a young woman who was living her best life. She was in her usual state of health, living her best life, and now she developed sharp chest pain. She has dyspnea, she has tachycardia, and elevations, which makes me think, because she doesn't have any cardiac risk factors and she was living her best life, that she now has developed myocarditis as well in this case. And remember that most common cause of myocarditis are going to be viral in terms of cause that we do know. Viruses, it'll be Coxsackie B virus. But again, it could be COVID virus or influenza. So most common overall will be idiopathic, and then viral is the most common known cause of myocarditis, making the best answer here, Coxsackie virus. But again, any of these viruses can potentially cause it, but that's the most common cause of myocarditis. So I hope this video was helpful for you. If it was, please like this video. Let me know that you kind of had something that you felt was good for this video. Again, comment on this video. Let me know what was helpful for you. What of this video spoke to your soul, right? Again, make sure you share this video. Sharing is caring. Share with all your friends and let them know about this video. And last thing, make sure you subscribe to this channel. So that way, when new videos post, you'll be the first to know. Again, you crushed it.